My name is Justis Ehlers. I'm a retina specialist at the Coli Institute in the Cleveland Clinic. Really excited to share some of the findings from our study. What we were looking at was in a natural history evaluation of intermediate AMD patients, some of the key biomarkers that we look at for evaluating progression. One of the challenges is in that earlier stage disease, we've had so much focus on geographic atrophy. What are our opportunities to understand how we could measure progression, not only for looking at risk, but also potentially for clinical trial design? So what we were really looking at is ellipsoid zone loss has been determined by the FDA to be an approvable endpoint, but identifying those patients who go on to total ellipsoid zone loss can be difficult. So we wanted to evaluate also sort of the impact of partial ellipsoid zone attenuation or degradation. And the way that we define that from a reading center side is essentially thinning of that distance between the ellipsoid zone and the RPE. The way to sort of think of it is it's sort of like outer segment thinning and that early damage that occurs. We've seen in different studies that this is linked to function, that it's linked to overall progression risk, and it's sort of just an earlier marker of that total EZ loss. Two reasons. One is it is an earlier stage of disease, so not everybody with intermediate AMD has total EZ loss, but a lot of them, if they have a certain amount of drusen that's there, have early outer segment thinning or this partial EZ loss. And with that allows us to get a better understanding of population behavior and understanding like who we would want to include in clinical trials. The other piece of it is that if we want to enrich for a population who's going to develop total EZ loss, we need to have people who are far enough along in the disease to actually get there. And AMD is a slow disease, and if we enroll people who have no EZ loss at all, no partial, no total, the odds of them developing a change in a year is really, really small. So what we found was that those were the eyes that clearly had more progressive, more rapid total EZ loss development and growth over time. So if you think about it, not only from like a patient sitting in front of you, that would be the patient who you'd want to treat if we had something for intermediate AMD to protect the photoreceptors. Similarly, if we wanted to enroll a group in a clinical trial, that would be the group that we'd want because they're the ones that are going to progress fastest, and we could tell, is the drug working or is it not at a quicker pace. I mean, right now it is tricky because we don't have these type of platforms embedded in our current clinical, sort of imaging devices. What we do have though is our skills as OCT interpreters. And if you start to listen to patients and they're talking about symptoms, things like dark adaptation, different sort of changes in their overall quality of vision. Their visual acuity may still be 20/20. If you really look, what you'll often see is some of these early changes where that ellipsoid zone may be closer to the RPE than normal. You may see some earlier changes there too. So the biggest thing for me, both with my patients who have GA and patients with intermediate AMD, is identifying what's the right cadence for surveillance, follow-up, potentially clinical trial offerings. Right now, we don't have a approved therapy for intermediate AMD beyond what we're using as over-the-counter AREDS supplementation. And so in some patients, for example, with GA who have more high-risk features but maybe aren't ready for a complement inhibition, I may be seeing them every 3 months for imaging because we want to capture them as soon as they make the decision to go for treatment. We want to be doing that as early as possible. Similarly, with intermediate AMD, instead of maybe seeing them once a year, maybe I'm seeing them every 6 months, trying to understand when we would want to intervene and how rapidly they're changing over time. So I think when it comes to biomarkers, I think they're already here. We have a well-established kind of group of biomarkers from hyperreflective foci to drusen complexity to ellipsoid zone loss that really a retina specialist should be able to look at an OCT and say, I'm concerned about this patient, and this is somebody who I want to watch more closely. And so at that qualitative level, we already should be there. At the quantitative level, where you say this person has 8% of their macula occupied with total ellipsoid zone loss or 332 hyperreflective foci, that's where we need the automated assessments. And it's really going to come down to one of two things. Do they get embedded in our diagnostics, which there's we don't have a timeline for that. The companies have to invest, to get approval to have those on board to be able to do that. Or are we using cloud-based solutions where we're putting our images up into some sort of AI platform to do that? It's coming, it will be there. And I think what's really going to help kind of push that is the idea of what we're seeing even in the GA therapy landscape. We know there are certain patients that if we had those parameters, we could better pair them up with therapy in the right way. So I mean, it's an interesting question. There's a lot of different ways. I mean, ultimately, AI probably touches every single aspect of the care delivery model. One aspect that I could share is at the Cleveland Clinic, we have an AI-based scribe system. And so that's used to actually capture, populate the notes. I will say it isn't the best for ophthalmology because our visits are frankly too fast. And right now we have to dial in on our phone, get permission from the patient. And I might be already halfway through my exam, in that. However, it's probably not that long from now where I'll walk into the room and it's just listening, and then I might be using it. I think also having, the type of, agentic AI intake, where you have, a chat system where the patient walks in and while they're in the waiting area, they're typing in and conversing with an AI bot of like what their experience have been and how that's populating. And so I think it's going to lead to more efficient practice deliveries of how can we, our technicians, our photographers are really valuable resources, and being able to use them at the top of their skill set and being able to potentially offload some of that. Those are things that I think aren't always thought of as much in terms of how we use AI. I mean, my passion for it is in image analysis and what it brings to that. And I think that's very clear that's going to be there too, but I think it's going to completely transform over the next 5 to 10 years how we do care delivery as well. Even doing like practice efficiency modeling, like how should we set up our templates so that patients can have a better experience, or where strategically do we have the greatest need for AMD versus DME, and being much more intelligent from an operational side of how we do things. And again, it may impact a smaller 2-person practice differently than a very large academic center, but I think that we're going to see that improving things in the way that we take care of our patients in the future. That's a really hard question, and honestly, it depends on the disease, and what you're really looking at. I mean, I'm fully biased in my perspective on the importance of ellipsoid zone loss when we look at outer retinal diseases. I think that if you had to pick a single thing for the everyday retina specialist to look at in dry AMD, that's probably the most consistent, easiest thing to see. It's probably hyperreflective foci. It's very consistent that if you have intermediate AMD with hyperreflective foci, that's a risk. What we also know is that you pretty much never have hyperreflective foci without underlying EZ loss. And so I think that there isn't just one. I think everyone's eyes see things in a little bit different ways. So you anchor with the thing that you're most consistent, most comfortable with, and can contextualize the way you take care of patients in the best way.